will discuss ichthyosis, which is fish-like skin, and it can be inherited or acquired. Amongst the inherited, it can be non-syndromic as well as syndromic. Non-syndromic has these four categories, which are the common ichthyoses, autosomal recessive ones, the keratinopathic ones, and others. The common two includes Ichthyoses vulgaris and recessive X-linked ichthyosis. These two are characterized by retention, which means that normally the epidermis is proliferating in 12 to 14 days, but there is retention of the stratum corneum. So it is a retention disorder. Now, the difference between two is that RXLI is earlier onset, vulgaris is later onset, and it is more severe, more medium to large brownish scales. Preauricular and neck involvement is there. Both have sparing of the flexures, which is antigubital, is spared. The Ichthysis vulgaris is due to mutation in the filaggrin gene, and filaggrin mutation causes corneocyte dehydration and then increase in pH, and then protease uh, activity is altered, leading to retention of the scale. However, in RXLI there is mutation of the enzyme STS, which leads to proteases increase like kallikrein 5 and 7, which are required for the corneodesmosome. So corneodesmosome is not proteolized, leading to increased retention. Hyperlinear palms are seen in Ichthysis vulgaris, and it is associated with atopy. RXLI is characterized by large scales, which this is in adult photo, and it has RXLI has association 3Cs like corneal opacity, cryptorchidism, and chondrodysplasia punctata. Placental sulfatase deficiency can also be associated, leading to prolonged labor and perinatal manifestations. Then moving on to the second part, which is the autosomal recessive congenital ichthyosis spectrum. These are due to broken lipid barrier, which causes increase in the transepidermal water loss. So this lipid barrier composed of corneocyte lipid envelope, cornified cell envelope, and the intercellular lipid lamellae. Harlequin ichthyosis, lamellar ichthyosis, and congenital ichthyosiform erythroderma. So harlequin ichthysis is due to mutation in ABCA12, which is required for the lipid transport pump, which is for the formation of this lamellar body. So these lamellar bodies are absent. So this cornicyte lipid envelope will not be formed. Transglutaminase deficiency occurs in lamellar ichthyosis, which is responsible for the formation of the cornified envelope, and thus there is disorganization of the lamellar bilayer as well. The CIE leads to mutation in allox E3, allox 12B, and Nepal4, and this leads to disorganized lipid bilayer assembly. They are characterized by the colloidal membrane at birth. Thereafter, there will be erythroderma, which will be more intense in case of CIE and harlequin ichthyosis. Less intense erythroderma will be seen in lamellar ichthyosis. When the collodion membrane is shed, then there is formation of these scales, which are larger plate-like, armor-like in case of harlequin ichthyosis, and synechiae are also formed. Mitt and hand deformities are seen. Common things are that there will be no sparing, there will be generalized involvement, erythema will be variable, palmoplantar involvement will be variable, all will have hypohidrosis, scalp abnormality, nail abnormality, growth retardation, vitamin D deficiency because of the large scale. Then lamellar will have large brown coarse scales, CIE will have fine white gray scales. This is harlequin ichthyosis with at birth with collodion membrane, armor-like membrane, then exfoliating erythroderma and palmoplantar involvement. This is lamellar ichthysis at birth with ectropin, eclidin, childhood photo with coarse, large scale, and then in enrollment, this is CIE with pronounced erythema erythroderma, and this is bathing suit ichthysis. So there are also, these were the three major variants. There are also minor variants like self-healing collodion baby, so normal skin after 3 months, acral collodion membrane limited to acral sites, and bathing suit ichthysis, which is temperature sensitive enzyme leading to warmer skin areas only has ichthysis. So this proximal extremities and trunk has ichthysis. Now we move on to the third one, which is keratinopathy group. So these will be hyperproliferative. This is also hyperproliferative, which means that lipid abnormality leading to basal cellular hyperproliferation. Here also keratinopathies leading to suprabasal cell cytolysis or granular cytolysis leading to hyperproliferation in the basal cell layer. These all are autosomal dominant. These comprise of epidermolytic ichthyoses, superficial epidermolytic ichthyoses, or IBS, ichthysis bullosa siemens, which is less severe form of epidermolytic ichthysis, ICM Kurth-Macklin, and PRIE reticular form. So both epidermolytic ichthysis and superficial epidermolytic ichthysis are characterized by large erosions, blistering at birth, and then erosions. This blistering causes infections, and there is pungent odor in EI, not in SEI. Erythroderma is more severe here, less severe here. After that, there will be hyperkeratosis, which is mostly limited to the joints and flexures. This has mutation in keratin 1 and 10. This has mutation only in keratin 2. Keratin 1 and 10 are basal layers. Keratin 2 is present in the granular layer. This, when the hyperkeratotic plaque is dislodged, it leads to the eroded base. Here, when it is dislodged, it leads to the Maserung phenomena, which means that the underlying skin is normal. If we see here, uh, 1 and 10, so 1 and 9 keratin is present in palm and sole. So, हाथों में नोनोचूड़ियाँ will remember that 1 and 10, 9 are present in palm and sole. So 1 if involved, palmoplantar involvement will be there, which is in epidermolytic ichthysis. Palm involved, blister and erythema at the birth, and then older childhood there will be hyperkeratosis. Superficial epidermolytic ichthysis present in the flexures, and the later form of EI we see the annular plaque. SCI is milder variant characterized by this Maserung phenomena, and epidermolytic nevi characterizing gonadal mosaicism. This ichthysis hysterics, we just have to remember that keratin 1 is mutated. Here porcupine or verrucous plaques are seen, shells are seen. And CRIE reticular variant, initially erythroderma is there, and then confetti like with increasing age we see these white spots. There is one variant, annular epidermolytic ichthysis, which is characterized by the granular polycyclic plaques. Then moving on to the last, which is a rare one, so loricrin keratoderma. It is autosomal dominant. Loricrin mutation, which is required for quantified envelope. It is characterized by these honeycomb palmoplantar keratoderma and starfish hyperkeratosis and pseudoanhemum. CIE or collodion baby is present at birth. Erythrokeratoderma variabilis, autosomal dominant, driven by GJB mutation affecting the connexin gap junction. It presents with transient migratory erythematous rash and then hyperkeratotic plaques. So these transient rashes, this is to be differentiated. This is EKV, this is progressive symmetric erythrokeratoderma. So this has fixed erythematous plaques that these can migrate. This is more commonly associated with PPK. This is less commonly associated with PPK, and this name has progressive symmetric, so it is characteristically symmetric. Then there is one disease which is click. Its name has keratosis linearis, ichthyosis congenita, and keratoderma. Then there is peeling skin syndrome, where very superficial mutation in the within the stratum corneum, so superficial exfoliation will be there. So it will lead to this peeling of the skin largely.